Good afternoon, everyone. Today I'll be talking about a topic very close to my heart, which is newborn hearing screening. The objectives of this lecture would be to discuss the importance of universal newborn hearing screening, to describe the different newborn hearing screening devices, and to discuss the Philippine situation. In the United States, approximately 1 per 3 babies out of 1,000 babies are born with hearing loss. This is at present time, and 36 states require hearing screening of all babies. However, in the past, in the 60s and 70s, only those who were high risk for hearing loss were tested for hearing loss. This is because there were no devices then that were efficient enough or fast enough for mass screening. These are the high-risk indicators: caregiver concern regarding hearing, speech, language, or developmental delay, family history of hearing loss, stay in the NICU for more than 5 days, in utero infections such as CMV, herpes, rubella, syphilis, and toxoplasmosis, craniofacial anomalies, physical findings such as white forelock associated with sensorineural or permanent conductive hearing loss, syndromes associated with hearing loss or progressive or late onset hearing loss, neurodegenerative disorders, culture-positive postnatal infections such as meningitis, head trauma, and chemotherapy. However, if we only use the high-risk factors to test, to know which babies to test, we would be missing out on 50% of babies born with hearing loss, but who have no risk factors. Just knowing this information, it seems to be prudent to test all babies who are born. But when do we test them? At birth, at 1 year of age, preschool, school age? Studies have shown that the first 3 years of life, when the brain is developing and maturing, is the most intensive period for acquiring speech and language skills. Even more important, better language development was associated with early identification of hearing loss and early intervention. And we are talking 6 months here. They compared those who were detected to have hearing loss and intervention was done before 6 months, and those who, when intervention was done after 6 months. And there was a great difference between the two groups. When left undetected, hearing loss of any degree, including mild bilateral and unilateral, has been shown to adversely affect speech, language, academic, and psychosocial development. This is why in 1993, the NIH Consensus Development Program recommended that all newborns be screened for hearing loss before leaving the hospital. And in 1994, the JCIH, or the Joint Committee on Infant Hearing, position statement recommended that all infants with hearing loss should be identified before 3 months of age and receive intervention by 6 months of age. In 1999, the American Academy of Pediatrics endorsed the universal newborn hearing screening. They also endorsed detection of hearing loss before 6 months and intervention initiated by 6 months of age. Alongside this, new devices were being developed, which were fast and efficient for newborn hearing screening. These are the Automated Auditory Brainstem Response Test, or ABR, and your Autoacoustic Emission Test. Autoacoustic emissions are sounds produced by the cochlea in response to acoustic stimuli. There are 2 types, your transient evoked and your distortion product. The main difference between the two is that with the transient evoked, you have 1 speaker producing clicks or broadband signals, and for your distortion product, you have 2 speakers, each one producing a pure tone. This is done on the baby by placing a probe assembly in the ear canal from which tonal or click stimuli are presented, and a microphone which picks up the OAEs generated in the cochlea. This is a very fast and efficient test, taking only about 1 to 2 minutes for both ears. The result of this test would be either a pass or a refer. A pass means that the integrity of the hearing pathway up to the cochlea is intact, and refer if a rescreen is needed. Rescreen would be done with the same device, and if the final result is still a refer, then the child will need to be referred to a physician, usually an ENT specialist, to further check the ears and for additional diagnostic tests to confirm the diagnosis. Now, the other test is your automated auditory brainstem response test. You can see on the left side, you have this big bulky machine, and to the present time on the right, where electrodes are sometimes not needed anymore. The AABR is an electrophysiologic measurement that is used to assess auditory function from the 8th nerve through the auditory brainstem. Generally, electrodes are placed on the forehead, mastoid, and nape of neck. And like I mentioned previously, in some devices, you don't need these electrodes anymore. Click stimulus is presented at 35 decibels via disposable earphones. Most AABR systems compare the newborn's waveform with a template or normative ABR infant ABR results. The result again is either a pass or a refer. Again, it is fast and accurate. A little bit longer than your OAE test, maybe 2 minutes longer, but nevertheless fast and very efficient. The result again is either a pass or a refer. A pass meaning that the hearing pathway to the brainstem is intact. And if the result is a refer, a retest using the same machine or another hearing test machine may be done. If the final result is a refer, then again, referral to an ENT specialist may be warranted. Now, the main difference between the ABR technology and OAE technology is that the ABR tests the hearing pathway up to the brainstem, while your OAE tests that portion of the hearing pathway up to your cochlea. The sensitivity and specificity of ABR and OAE are also not that far apart, although we can see that the ABR has a slight edge over your OAE. Of course, with all this information abroad, research was also started in the Philippines, and our data shows that the prevalence of bilateral profound hearing loss is 1.38 per 1,000 babies born. This was done by Dr. Chong in 2007. We can also see that it is the most common congenital anomaly. It is more common than the metabolic diseases that we screen for in the newborn period, like congenital adrenal hyperplasia, congenital hypothyroidism, G6PD, galactosemia, and phenylketonuria. Other tests were also done, which pointed the way for us that newborn hearing screening was very important. And because of this, in 2007, the Philippine Society of Otolaryngology Head and Neck Surgery task force was created on newborn hearing screening. And they submitted a position paper stating the importance of universal newborn hearing screening. This was also the time when the collaboration on newborn hearing screening advocacy was started. And this is the group, along with the other groups, that pushed for mandating universal newborn hearing screening. In 2009 was signed into law by the President of the Philippines, then Act 9709. The key of this law is that these be 3 months of age, and there are also early diagnosis and definitive intervention for hearing loss. Includes the cost of hearing loss screening and its benefit and the program to gradually increase the coverage from hearing screening to diagnostic evaluation and intervention services. Another is that audiologic centers will be identified, those centers for screening only, or those centers capable of doing diagnostic testing, as well as intervention centers. Certification courses for screening technicians are also being done to train potential screening technicians. These results are sent to the Newborn Hearing Screening Reference Center based in the NIH. As of 2012, 216 individuals have been certified to perform newborn hearing screening. 83 hospitals have been found to be capable of performing newborn hearing screening across the country, and 33 hospitals have been found to be capable of performing diagnostic hearing tests. As of present, the 2014 data, we have two examples of hospitals performing universal newborn hearing screening, which means that all newborns are tested before they leave the hospital. In one private hospital, about 2,000 babies are screened per year with a 3 to 5% refer rate and a very good follow-up, a 98% follow-up for rescreen and diagnostics. In a government hospital, 1,157 were screened with an 18.5% refer rate. That is quite high, maybe because of the population of those screened, maybe they're really very sick children. And the sad news is that only 41% followed up for rescreen and diagnostics, maybe due to lack of funds or they don't understand what the procedure or the newborn hearing screening. Now, these are just the initial steps. We still have a lot of work to do. For example, after screening, the child will need diagnostic tests, like your diagnostic ABR, your auditory steady-state response, maybe pediatric audiometry, and possibly what is new today is your central auditory evoked potentials. And after that, you need intervention with the use of hearing aids, implantable hearing devices, and if this is not affordable for the family or because of their choice, they can also take sign language or total communication. Now we have other issues as well with regards to newborn hearing screening. For example, babies born at home, how will they be screened? Babies who are lost to follow up or do not show up for repeat tests or diagnostic tests, how will we make them follow up? And the next would be PhilHealth coverage for diagnostics and intervention. Talks are now on the way or ongoing regarding PhilHealth coverage for the diagnostic ABRs as well as hearing aids. Now, that ends my lecture. Thank you very much.